Okay, so just as a disclaimer, so the views expressed by the speakers and the workshop facilitators not necessarily reflect the views of the opinions of the organizing groups. And like I said before, we can have questions submitted at any time through the question and answer chat, and those will be answered through the speaker panel. Okay, so we are a few minutes early here, but if Dr. Dobiesz is here, we'll be happy to have you speak. Okay, great. So let me just give a brief introduction here. So Dr. Dobiesz is an emergency physician at Brigham Hospital. She's the director for the Front-Line Indigenous Partnership and faculty at the Harvard Humanitarian Initiative. Today she'll be talking about the FLIP partnership and the Ohiyesa Premedical Program, which supports tribal and community college students interested in pursuing careers in healthcare. So we're very excited to have you talk today.
Thank you so much, Cameron. This is amazing to be a part of this initiative, these efforts, and I cannot thank you enough for being able to be here today. Can I share my screen?
Yes, you should be able to.
Okay, share. Do not be frightened by my my desktop. I know that's scary good to many of you. There is order in the chaos, I must say. Okay, is that better for some of you? That I didn't want to hurt your sensibilities there. So again, thank you so much. I am so honored to be here during this session. I would love to share with you a bit about our program, which is the Front-Line Indigenous Partnership Program. And a little bit about us and where we're based. As Cameron said, I'm a physician, emergency physician at the Brigham and Women's Hospital. This program is based in our department as well as the Harvard Humanitarian Initiative. And in particular, we have an Office of Ideas, which is inclusion, diversity, equity, and social justice. It's a very important part of our emergency department, our mission, our goals. And we're also affiliated with the School of Public Health as well. So just the goals of the session, I just want to share with all of you a bit about the work we're doing and honestly to hear about the work that you are doing. Some background into how and why we were formed and our program started. This has to do with health inequities in Indigenous peoples globally, but also that are mirrored very much in our own country. We know that Indigenous populations are at higher risk for diseases, in particular things like diabetes. So around the world globally, over 50% of those Indigenous populations over the age of 35 will have type 2 diabetes, very prevalent. We know that the life expectancy is much less in Indigenous populations around the world for men and women, the United States included. We also know that the social determinants of health, that Indigenous populations are much more or disproportionately at risk of being in extreme poverty, which relates to many disease processes and tuberculosis, lack of access to quality health care, medications in this perpetuating cycle. We do know that maternal and infant mortality is much greater in Indigenous populations, and again in the United States as well. Malnutrition is a significant issue for Indigenous populations. There are many reasons for that. Has to do with land and degradation of land, environmental context. So many reasons for this. Also, I just wanted to highlight the effect and impact of colonialism, and that has structurally impacted many Indigenous population and their Indigenous people's rights to communal assets and self-determination. And we know the lingering adverse effects of colonialism on the health of Indigenous populations is significant and around the world. So also that they suffer disproportionate, irresponsible use of toxic chemicals and waste for Indigenous populations. And I want to highlight for everyone here, we know this, but we need health systems that are appropriate to the Indigenous context. And so that is sort of a baseline understanding, and I think we all know that. And part of the reason we were, and actually a major force of our program. So we were started, so the Front-Line Indigenous Partnership program began at the fall of 2020. So we're new. And this was during the height of COVID. So everybody remember why we're virtual, why all these conferences are virtual, is this pandemic, residual from that. And during that time, all the health inequities and disparities were disproportionately shown. We know that for people of color, for Indigenous populations. Native Americans were 3.5 times more likely to get COVID at that time than white populations. And there was a generous donor who was compelled, several donors were compelled to do something for this disparity, especially for Indigenous communities, for Native Americans. And Mike Van Rooyen, who leads the Harvard Humanitarian Initiative and is the chair of emergency medicine at Mass General Brigham, he was able to facilitate this donation and form this program. And I was honored to be able to lead this program and this initiative. So what are we? Who are we? What are we doing? Our mission is to improve Native American health and to eliminate existing health disparities. That is our goal. We want to empower emergency medicine healthcare providers that serve Indigenous population to provide the highest quality care through education, clinical, and administrative partnerships. That's kind of our mission, our vision, and why we're in existence. And a key to our success and the work that we're doing is the partnerships we are creating. And during this time, we were lucky because we had incredible partners that we could collaborate with. So Dr. Sean DeAndrea was a Brigham and Women's Hospital physician. He did a global health fellowship, and then he went on to lead a hospital at the IHS. And he is currently the vice chair of the National Council of Clinical Consultants at the IHS, and has been instrumental in our development of our program. And Ken Bernard, who was a Hammer resident, which is a Harvard affiliated emergency medicine resident, who was one of in our program, in our residency program. He is of the Turtle Mountain Band of Chippewa on the Great Plains. He worked at Tuba City in the Indian Health Service. He also formed a company that was primarily Native American owned and staffed with the highest quality of care physicians for the Indian Health Service. His mission was to improve the quality of care. So these were our primary partners who were instrumental in getting us started. So what are the components of our program? We are involved in clinical exchanges, educational programs and support. We have an online LMS platform. We support the annual Native American and Emergency Medicine and Rural Medicine Conference every year. And this is really exciting, and something I want to highlight is the next phase is into developing pipeline and healthcare professional development programs that we're very excited about. This is the team, a really dedicated group of individuals. Andrew Eyre leads our educational program. He's an emergency physician, a simulation specialist. Dr. Tim Erickson, he's an emergency physician, a toxicologist. He has been instrumental in our clinical exchanges. Katie Dickerson Mays is one of our Hammer residents. She's an emergency medicine resident and is leading the emergency medicine residency initiatives. And Anna Meyer is the director of our emergency department nurses. So we have a nursing component as well. We could not do this work without program management. Jay Hall and Cassandra Georges are phenomenal and have been just inspirational. They are based in the Office of Ideas, and again, that's the inclusion, diversity, equity, and social justice. So just going to highlight a few things that we're doing. We are now, so we said clinical exchanges. So what does that mean? We are now helping to staff the Sehutsui Medical Center in Fort Defiance, Arizona. It's a tribal hospital, not an IHS hospital, but it's a tribal hospital. And since October of 2021, so we started working there. And we have basically a full-time equivalent faculty position there. And we have faculty there that are every month. It's not the same faculty. So we have multiple faculty that are starting to work there clinically to support their staff. And so I work there in December, and I also work there in March. So important to know the context in which the healthcare is being provided. Sehutsui Medical Center, I should say, is very near Window Rock, which is the heart of the Navajo Nation, the spiritual center. It's an amazing place. So this has been a remarkable experience for our clinicians who have gone out and continue to do that. We have one of our physicians, the third from the right, John Strong, who's with the team. This is really a dedicated, committed, extraordinary group of individuals working there. It's a great place to work. This is what the inside of the department looks like, a little bit of the center. And what I would say is working there, we don't have a great deal of access to specialty care. So often significant trauma or specialty care has to be transported out, mostly by helicopter and planes, some ambulances. And I would tell you, working there, those of you who have worked in the Indian Health Service or at a tribal hospital, when the weather is bad, and you have a difficult, challenging case, it can be quite challenging. And I have a healthy respect for those that work in this environment. We have a Brigham apartment. We call it the Brigham House. This is where we stay when we're there. So we're literally right in front of the parking lot. So we walk, it's a 2-minute commute to the hospital when we work there. So our goal is to be there and to be there for the long haul. So we've set up a nice little facility. Just sharing the special place that it is. This is the Hogan in the Wellness Center at Sehutsui Medical Center. And again, that's Dr. Strong, John Strong, who was one of the first physicians out there, and an incredibly beautiful spiritual special place to be and to work. And the people are extraordinary. So that's our clinical exchange. We talked about one of the other missions that we have are educational exchanges and support. So we've developed monthly didactic sessions. We alternate on who does that. We do one, and then the faculty or the APPs at Sehutsui will do another, like a case presentation. And so we have discussions. We archive these and we put them on our LMS site so that others can look at them later. And, hopefully we can have a nice resources for these materials. The other one of our main missions was to support this Native American and Emergency Medicine in Rural Conference. This was the 3rd annual, and so well, not unfortunately, it's just, you know, a side effect of the COVID pandemic. We weren't able to meet in person, and so we did it virtually. We were able to transform it into a virtual conference and to support it. And we talked about the LMS system. This is part of our website and our web page. So we recorded all of these presentations that occurred, and it's open access to those in this environment so that they're able to access this. Another of our initiatives is, we know that we did a needs assessment from a lot of the directors. Some of them tend to be young, have not had a lot of management skills, how to run a department. So we're creating an IHS Emergency Department Directors Consortium to help them, support them, and give them the skills that they need. So that's one of our initiatives. Another area that we've really done a lot of great work is with nursing exchanges and nursing support. And Anna Meyer, who is our director in the emergency department at the Brigham, has been phenomenal, has done a lot of work at Gallup at their Indian Medical Center. And it continues to support various departments with education, administrative support. Like everywhere, we've had a huge turnover of nurses, and the Indian Health Service is not immune to that. And so they've had to build up systems to be able to train and onboard a great deal of nursing and traveling nurses. So she's been instrumental in that. In the lower right, this is before our program started. We have a history of working in the at Gallup Indian Medical Service, doing some courses in the past. This is our resident representative, Katie Dickerson-Mays, who's extraordinary, has been phenomenal in creating this rotation for our residents. Next year, we will have 5 of our residents who will rotate and do an elective at Sehutsui Medical Center. So that's kind of an overview of the FLIP program. And there's one last component I wanted to share, and I'm very excited about this, about, you know, not just the capacity, but we want to have culturally appropriate care and the best, highest quality care. And I don't know this context. I don't know, I wasn't raised there, and I cannot understand it in a way that an Indigenous or Native American might be able to. And so what we know is we're lacking in healthcare providers on a very large level. So Native Americans make up 3% of our US population, but only 0.002% of the physicians. We know that 9% of medical schools have only 4 Native medical students. I think Harvard is one of them, HMS, and 43% of medical schools have no Native American or Alaskan Indian students at all. And very few of our medical school faculty are of Indigenous or Native American origin, and we're lacking. The pipeline is not good in healthcare providers of the future, which is incredibly important. And the disparity is that Native Americans and Alaskan Indians have greater than average rates of 15 of the 16 leading causes of death, which is not okay, not acceptable, and we need to make major strides in this. So one of the programs, and I believe Victor, Victor Lopez Carmen is an HMS student, my co-lead and co-founder of the Ohiyesa Premedical Program. And I think he was invited here. He is an extraordinary, incredible person, individual. And I want to share a little bit about this program. So Victor is a member of the Crow Creek Sioux Tribe. He is also co-chair of the UN Global Indigenous Youth Caucus. He has just been an extraordinary collaborator of this program. And Ohiyesa is named after his great-great-grandfather, who was the first male Native American to become a physician in the US, Dr. Charles Eastman. So how profound. So to have his great-great-grandson at HMS founding a pipeline program, a professional development program. So we have been working on this for over a year and a half to create this program. And we are thrilled that it is coming to fruition. So this summer, we will have 8 Indigenous students that apply to our program who will come for a year-long program, which will start with an immersion program 3 weeks in Boston. So they're going to arrive June the 24th, and they'll be here till July 15th. And they will have shadowing experiences in a variety of clinical settings. They're going to go to, I work at STRATUS Simulation Center, so they're going to spend multiple hours there practicing skills. They're going to become CPR certified. And they're also going to have sessions on the medical school pathway, how to apply to medical school, how to, what the necessary skills are. And and we're going to support them throughout the year. So we will meet with them periodically, virtually, once they leave as a cohort to support them in their academics and their pathway with their questions, and attach them to other medical students who can be mentors and to help sponsor them in their journey. They represent, the 8 students that we have represent 7 different tribes around the country. And we couldn't be more thrilled with the cohort, with the group. It's just amazing. So that's the Ohiyesa Premedical Program that's about to launch. And I just wanted to open up. So we had 2 years of funding for this program. And what we're looking at is the program of the future, again, is in this professional development pipeline. So what we're looking to do is expand exponentially these professional pathway programs. And some of the areas and collaborations, which is exciting across the university. We have been a part of this Harvard University Native American program, this consortium. So we're learning about other programs around the university who are working with Indigenous health and have been collaborating. There's an ARC Health collaborative that we've been a part of, who link academic centers with Indian health services. This is a very exciting part of moving forward. We've been able to collaborate with the leadership of the Association of American Indian Physicians. They have a program where they bring high school Indigenous students, Native American students from around the country to Washington, D.C., about 30 students, high school students. It's called the Patty Ironclad National Native American Youth Initiative. We want to help sponsor. They lost their funding, and we have been collaborating with them to be able to do that. They go to Washington, D.C. They visit the IHS, the NIH. They get exposure to medical careers, so we're super excited about that. I've been collaborating with the University of Utah. They have a community health program for Indigenous youth to work at IHS sites, so we're going to working with them to collaborate in the future, as well as UCSF. They have a HEAL initiative with fellowships and programs. So we're looking for them. We've designed a program for nursing and developing a nursing pathway to support Indigenous youth into that. So thank you so much. I'm trying to be on time and be, making sure I didn't go overtime, to share with you a little bit about our program, the Front-Line Indigenous Partnership Program. We're new, we're nascent, we're hoping to grow and build on these health professions, professional development programs, the youth of the future, in order to give that high quality, culturally relevant care that is needed. We know that that would improve the care for Indigenous populations, our Native Americans in this country. So that, I believe, is it. Went through that hoping to keep us on time, Cameron. So anyway, I'm sorry if I went a little fast, but I was super excited. I can't help myself. But just to share a little bit about our program. I don't know if we have time for a few questions, or do we wait for the panel?
Yeah, that was very excellent. So I'm looking forward to the summer program, and let me know if I can help out at all.
Yes, the answer is yes, you can help.
Okay, good. Yeah, and I guess not everyone knows this, but you've been a doctor all over the world, worked with many communities. So I guess I'm just wondering, how are Native communities and those needs different from other communities, and the needs of that you've seen in other places?
It's similar. Global health. It actually saddens me. I cannot tell you how much to go to our own country and see a population that doesn't have electricity, safe water, that we tolerate that in our own country. It's like a global health issue of vulnerable populations, those that have been historically disadvantaged, structural racism, historic, policies that have taken away land and rights, and it's no different. The needs, it's most shocking and most disturbing and upsetting that it is in our own country that we allow that to perpetuate and to continue. And even still to this day, taking away tribal land, taking away when they need the pipeline, when they need, it continues. It hasn't dissipated. So I would say the need is just as important in our own country. You don't have to travel elsewhere to find similar problems of disadvantaged, vulnerable populations that have had sustained these structural barriers and racism throughout a long period of time.
Right.
Yeah.
And we do have a question from the audience here. We have a few minutes before Tina starts. So you talked a little bit about bringing physicians and also nurses to Native communities. Are there any thoughts about bringing other healthcare workers? So someone brought up like dietitians or physical therapists or anything else that might be helpful in addition to physicians and nurses.
Yeah. So we actually, the need right now is ultrasound and ultrasound training. And so we're bringing some technicians at the moment. It's about what the needs are and how to best meet those needs. From within the community, they have a lot of support. They have a lot of mental health workers. They have at where we are. That's not saying other sites don't have that. They have a very strong, support system in a lot of things. So we're using, it's a needs assessment. What do they need most? And how do we best fill that need? So there are roles for lots of different types of, healthcare provider professionals that can assist. We're just meeting the needs that are there at the moment. So, and trying to best fit those needs. Actually, what we're trying to do is build up those healthcare providers, nutritionists, from within, from the community.
Right.
So that best serve the community.
Right. So we have a couple more questions that are coming in now. So I guess these are two questions, I suppose, but so as far as the residents that you're sending there, if you're what kind of like preparation do they have? And then how, you mentioned that people live essentially across the street from the hospital. What kind of programs are going on to like build trust within the community?
Great questions. So we are, We are relying a lot on those that are there now to help guide us. They have an orientation, and we've created an orientation sort of manual and for each of us that go there to try and understand the context and the people and sort of what we see and how best to address it. So we have relied on those that are currently there and working, but also we're building up. So before each of us goes, we have a manual that we're building up about some of the resources, the patients, how to be render the best possible care and be sensitive to the issues there in the environment. So we're trying to help each other to be better at it and engage with the leaders in the area. We're starting to expand into that to find out other ways in which we can help the community in which we're working in.
Yeah, it's really great to hear. Okay, I think we have a couple more minutes here if anyone has any other questions.
And I guess I wanted to bring up maybe one point I didn't. The type of students we're bringing are we're targeting tribal community colleges and community colleges in general, because they have the least resources in pre-medical preparation. If you're at a university, if you're here at Harvard, you would have more access to pre-medical programs and shadowing experiences. So we are targeting those at tribal colleges that don't have access to that. So anyway, that's a unique part. There's other wonderful programs you'll hear about, 4 Directions and research and lovely. We're not a research based. We're looking at tribal earlier in their careers to help mold them. So trying to be synergistic and another opportunity for students that have less access to resources.
Yeah, and I think that was really, sorry, I think that was really important for me when I was a post-bac program, that I wanted a few things to like have a mentor, and it sounds like you have great mentorships that you're setting up. And then also to really have experiences that would motivate me to want to study and learn and be a better physician. And I think that it sounds like you're having those shadowing experiences to really get students in the hospital to see the kind of work that they could be doing.
Right, and surgical, medical, mental health, psychiatric, neurodevelopment, like we're trying to really give a broad exposure to lots of possibilities.
Okay. So I think that's all the questions we have. Valerie, thank you so much for coming today. I know that you have another meeting to run to, so I won't keep you.
Well, thank you so much for organizing this, for all the work that everyone is doing, and really an honor and a privilege to be here with you all today. Thank you so much. Really appreciate this opportunity.
Yeah, thank you. Appreciate it.
All right.
All right. Tina, are you